Yeah, we're really very grateful for everyone turning up today at what's an unusual time for our neuropsychiatry meetings, but it's because we have a very special guest who is in London and isn't here on a usual slot, and he certainly deserves his own slot to tell us about his exciting research and his clinical work. So today we're very, very happy to have Professor Dominique Endres from the University Hospital Freiburg in Germany. I went to Freiburg for the first time quite recently. It's beautiful and it's a wonderful little university town. But Dominique Endres is a professor of psychiatry and has been co-leading a rather unique clinical and research group there, along with Professor Ludger Thebarts van Elst, and they're really taking a sort of almost a radically different approach to the assessment and in some cases the management of patients with psychiatric disorders. And Dominique will be sort of working through some of that today. It's been particularly sort of influential to me because it's really shown quite the extent to which, if you look for interesting secondary organic causes of psychiatric syndromes, you really do find them. And I'm sure we'll be hearing something about that today. Just a few points of order as ever. We are recording the meeting, and the recording will be available to people from King's and SLAM, but we're afraid not externally after the meeting. Can we remind you please to mute your microphones and switch off your camera? Don't take control of the slides as this disrupts the presentation. And you can also ask a question by either writing it in the conversation or by raising your hand. And if you raise your hand at the end, I'll come back on stage and you can switch your camera on when I ask you to, and you can ask the question in as close to real life as possible. Of course, people in the room can ask their questions here. If anyone needs captions for hearing impaired, select the 3 dots on the toolbar and press turn on live captions. So we'll move straight on to the talk now. We're very pleased to have Professor Dominique Endres talking about immunoneuropsychiatry from a clinical perspective. Dominique.
Dear Tom, thank you so much for the invitation and the introduction. Dear ladies and gentlemen, it's a great pleasure for me to be here and to talk about immunoneuropsychiatry from a clinical perspective. So I'm a psychiatrist and will present the clinical view on this topic. So why it can be important? I think it is important to look on this topic because we still have a high number of therapy resistance in psychiatry. And this leads to high costs and especially to the situations that we cannot treat all the patients successfully. And this leads to often strongly reduction of quality in life in these patients. And what do we know about autoimmune causes of severe mental disorders? We know that there is a strong association, and we know that from register data from Denmark and Sweden especially, we know that autoimmune diseases increase the risk of developing schizophrenia or depression, and the numbers are for schizophrenia. We know that a previous autoimmune disease increased the risk of schizophrenia by 29%, and the previous hospitalization for an autoimmune disease, so a more severe type, increase the risk of depression by 45%, and vice versa. We know that patients with OCD have a 43% increased risk for an autoimmune disease. And finally, we know and we have learned from NMDA receptor encephalitis that antibodies can lead or cause psychiatric symptoms. The NMDA receptor encephalitis was first described 2007 by Joseph Dalmau, and 1 year later he summarized the first 100 cases, and he described that most of these patients, 77%, were initially seen by psychiatrists. And this is because many of these patients developed initially psychotic symptoms, and so the topic is important for psychiatrists, and at least because we have a good outcome with immunotherapies in these patients. Here in this larger study, in 81% after 2 years. And yesterday we heard this wonderful talk about landmark case reports, which were important for psychiatry. And this was my personal landmark case report, because this was my first case I have seen with an autoimmune encephalitis. During that time, I was a doctoral student, and there was a patient on the ward, 30-year-old female patient with a severe catatonic schizophreniform syndrome. She was absolutely not speaking. She has a catalepsy, severe hallucinations, and this syndrome went on over 2 years. And interestingly, initially she had one epileptic seizure, but not anymore in the further course. And an admission to a nursing home was already planned. And she came to our hospital to get a second or third or fourth opinion, I don't know in detail, but the investigations were done by this patient, and the EEG showed a slowing, non-specific. CSF analysis showed normal white blood cell count, no oligoclonal bands, but initially she had a slight pleocytosis, and the MRI, you see it here, looked normal. So the question was, does this patient have a severe catatonic schizophrenia, or can we do further investigations to get a secondary cause? And Professor Teberton-Els and Professor Perloff, which were responsible for the patient during that time, they added a PET imaging, and the findings were very interesting. You see here the hypometabolic areas in the PET imaging, and you see the whole left hemisphere showed a hypometabolism, also on the other side, but mainly on the left hemisphere. And I did my doctoral thesis about MR spectroscopy in ADHD, and we measured large patient groups, but there were no overall group differences mostly. And then we had this patient, and we looked in the prefrontal cortex, and we found that here in the prefrontal cortex, the glutamate was strongly decreased. And also on the other side, compared to our control group. So now we had on a single case level a strong signal in the glutamatergic system, and we thought there might be a problem. And in line with that, the patient had NMDA receptor IgG antibodies, the ones which are associated with NMDA receptor encephalitis. So the diagnosis was done for an NMDA receptor encephalitis. The patient was treated with steroids, plasmapheresis, and this led to a nearly full remission. And you can see the PET images here, which have normalized greatly. And so the patient, she went not to a nursing home, but she went back to work again. And this was very impressively for me. In the meantime, we have a 10 years work follow-up of this patient. She still has slight residual symptoms, sensory overload. So she's not able to work the whole day. She can work 4 or 5 hours a day, but it's much more than living in a nursing home. And she's very happy about that and very active in motivating people doing organic investigations. And nevertheless, today, I think this patient would be diagnosed as an encephalitis because there were many red flag signs, severe catatonia, epileptic seizure, slightly increased white blood cell count. But during that time, it was a relatively new thing in psychiatry. And this patient and some other patients led to the situation that in Freiburg University Hospital, we offered lumbar punctures to all patients with psychosis since several years. And in the meantime, we have a relatively large cohort of patients. And we also did many research studies on this very important biomaterial, if patients agreed. But I will not focus on these studies, but more on the clinical, practical things which we can learn from that. And in this regard, the routine diagnostic findings are the most important. And what we see in nearly 1,000 patients is that 18% of the patients had an increased albumin quotient, so a disturbed blood-brain barrier, but this is a non-specific signal. And if you look on white blood cell counts, IgG index, and oligoclonal bands in CSF, and summarize that, we find clear-cut inflammatory CSF changes in 8% of our patients with psychosis. And we had the hope that many of these patients had well-characterized neural antibodies, although in the CSF, and these patients were analyzed mostly in CSF using fixed cell-based assays, and looked for NMDA receptor antibodies, but also for the other well-characterized antibodies against cell surface, LG1, Caspar2, and so on. And in the serum, we also looked for the paraneoplastic antibodies in these patients against intracellular antigens. We only looked for the IgG type antibodies, which are associated with encephalitis. And we found antibodies against cell surface antigens, such as the NMDA receptor, in the serum of 1% of these patients, and the CSF only of 0.3%. And these were only slightly positive NMDA receptor antibody findings. And the neural IgG antibodies against intracellular antigens were detected in the serum of 0.7%. So the well-characterized neural antibodies against cell surface antigens were very rarely positive in the CSF of our patients. So the initial enthusiasm was reduced a little bit, but nevertheless, in this group, we had several very interesting cases, which we sometimes published as case studies. Just to mention one of these cases, this was a young female patient with an acute polymorphic psychotic episode, which developed very fast over 2 or 3 days with severe hallucinations, hearing voices, paranoia, or hearing her voices, hearing her thoughts. This is wrongly written. And she had an acute diagnostic workup, therefore, in an external neurological hospital. MRI, EEG, CSF were done, but there was no clear cut alteration. And after discharge, the patient got the information from the colleagues that the NMDA receptor antibodies were positive in the serum, but not in the CSF. And then an outpatient treatment was introduced, and the patient was 2 months at home, but she was nearly there was an inability to live alone, so she was living with her parents again, and she had severe cognitive deficits, affective instability, was unable to sleep, anxiety, so no clear hallucinations anymore, but she was severely in, and then she was admitted to our hospital for a second opinion, and we repeated the diagnostic investigations, and the MRI again was nearly normal. We had some atypical white matter lesions for this age, but this is nothing specific. You can see it here. The EEG was normal. The NMDA receptor antibodies in serum were still positive, but they were negative in the CSF, and there was no inflammatory sign in the CSF. So again, the question was, what should we do with this finding? Is this a non-specific finding? Oh, I don't know, what would you do? We asked ourselves, is it a non-specific finding? Because we know that even in healthy controls, NMDA receptor IgG antibodies can be detected in 0.4% of patients. These are studies from Göttingen in Germany, from Hannelore Ehrenreich. Nevertheless, we added PET imaging in this patient, and there we found a classical encephalopathic pattern in this patient. The typical thing we see then in these patients is a combination of hypermetabolic areas. You see it here in the upper line, along several regions, cortical regions, especially in the association cortices, and in connection with the hypermetabolism of other regions. You can see it in the primary cortices, especially here. The patient had no tumor, but she had an NMDA receptor in the serum and this encephalitic pattern in the PET. So we thought it must be a mild form of NMDA receptor encephalitis, and we started a therapy with steroids. And normally often it is not enough in patients with NMDA receptor encephalitis, but in this patient, she had a very fast improvement. And in the week after the steroid pulse, she said she has a big improvement and she wants to go home. So we had repeated the PET imaging, and you see the follow-up here. So it's a very close follow-up, but the hypermetabolic changes, they were nearly normalized already, and the hypometabolism was not available there. And in the following weeks, there was a full remission of this patient. So what can we learn from these two patients? Catatonia and acute polymorphic psychotic episodes are suspicious of an autoimmune psychosis, and we can achieve a full remission if we treat early. But the second case also brings some questions, because if the antibodies are negative in the CSF, how should they make anything there? One explanation would be that the tests are not sensitive enough for such psychiatric cases. Another reason might be that all the antibodies might be binding to brain tissue. There is an idea that the brain can work as an immunoprecipitator in such cases. but it shows the importance of a multimodal diagnostic workup in such patients. But nevertheless, we only had small numbers in our hospital, so we said we have to look in the literature, and we summarized all the cases of autoimmune encephalitis and an isolated psychiatric syndrome. And until 2018, these were 145 patients we found. And again, we distinguish between patients with autoantibodies against cell surface antigens, versus most patients, antibodies against intracellular antigens, so the paraneoplastic ones. And we also looked for Hashimoto encephalopathy, so patients who responded to cortisone in the context of Hashimoto thyroiditis. Overall, we found more female patients in this analysis. The patients were 44 years in mean age, and the patients with paraneoplastic disorders were the oldest. This is logical. Most of these patients had NMDA receptor antibodies, but you can also see that the spectrum was relatively broad. And most of these patients had schizophreniform syndromes or dementing syndromes. But again, the spectrum was broader than we initially thought. There were, for example, also 2 patients with an autistic regression in the context of an NMDA receptor encephalitis. Very important was also that the age peaks were between 10 and 19 years. So also for younger patients, this topic is important, and between 60 and 69 years. So there might be more the paraneoplastic ones. And as I said, most of these patients had dementia or schizophreniform syndromes, but not always. And the same is true for the NMDA receptor antibodies. They were the most positive antibodies, but there were also association with other antibodies. Most of these patients were detected by CSF pathologies, and EG was positive in 60%, and the MRI was abnormal only in half of these patients. So this is also important to mention, that a normal MRI does not exclude an autoimmune encephalitis, and tumors were detectable in 22% of these patients. And there is surely a strong publication bias by looking on the treatment effects, but from these patients, 78% received immunotherapies, and there was an improvement described in most of these cases, and most of these cases get steroids, immunoglobulins, or plasmapheresis. In Germany, we started then to collect such cases in a database, and the neurologists in Germany, they have established a network all over Germany for autoimmune encephalitis cases, the GENERATE network. And we then started the Neuropsychiatry database, a sub-database for the psychiatric manifestations. And last years, we have published the first 91 patients from this database. So these were purely psychiatric cases. There were many patients only having possible psychiatric form of autoimmune encephalitis. Only 21 had a probable psychiatric autoimmune encephalitis. And what we can see here, and also very interesting, most of these patients again had a schizophreniform disorder, 53%, but the other half of the patients had other psychiatric syndromes. So the clinical spectrum might be broader. Many of these patients had a previous mental illness. Also, this is important if you have a patient in the emergency situations. An earlier psychiatric or mental illness does not exclude an autoimmune encephalitis. And again, the CSF was abnormal in most of these patients and was the most sensitive signal. Here we had in 75% also MRI alterations. And not all of these patients received immunotherapies, but most of the patients showed an improvement. But again, this case series has many limitations because these are judgments from the physicians, and it is not a prospective controlled study. But what we can learn from this is that psychiatric manifestations of autoimmune encephalitis exist, and we use the word autoimmune psychosis, and the paper from Tom Pollack was so important in this regard because it gave the first guidelines for dealing with such patients. So his suggestion, or our suggestion, was to look on clinical signs, clinical red flag signs, and if they are available, to do further analysis, at least in these patients, and then to classify in patients with probable and definitive autoimmune psychosis. And if you have an antibody against an IgG epitope, then we can speak of a definite autoimmune psychosis, and we should consider immunotherapies in these patients. And the most established therapies are steroids, as I have shown, immunoglobulins, and the therapeutic apheresis, plasmapheresis. Rituximab is more and more important, but there are also a number of emerging therapies, for example, proteasome inhibitors. There are currently trials in Germany regarding this, and some very interesting potential therapies. So just to mention one of them, if you look on the idea of CAR T cells, it would be wonderful to have one day the possibility to selective death NMDA receptor producing B cells, and not to stop all the B cells. So this would be really a step for precision medicine in neurology and even in psychiatry at the end of the day. But it's also important to mention that these are off-label treatments, that there are potential side effects. So we have to look very well on our patients and to decide in which patient we should do an immunotherapy and in which patient we shouldn't do that. And in our hospital, we always do a multidisciplinary discussion about treatment in these patients with a psychiatrist, with a neurologist and a rheumatologist, so not to over and not to under diagnose and treat these patients. But for these patients, antibodies in the CSF, we have clear guidelines, and I think the approach is relatively clear. But if you work on the ward, you have more the borderline cases. So you have a patient, for example, without neural antibodies, but with red flag symptoms, for example, with a severe catatonia or an autoimmune predisposition, and perhaps you find oligoclonal events in the CSF, but you have no neural antibodies. But what is then? What is with these patients? And I think they are much more complicated. And we asked ourselves then, are there perhaps psychiatric anti-CNS antibodies which are not known from neurology? And how can we look on them? And then we started a wonderful cooperation with Harald Prüss from Berlin, who established a test, an antibody screening test on unfixed murine brain tissue. This test is very sensitive because it is unfixed, because there is no denaturation. And then we are looking whether there is any antibody binding against special CNS structures. And the first patients we analyzed were patients with a severe type of catatonia. For example, this patient again with PET changes, or this patient with strong EEG changes. And in these first cases, we had, in these two cases, we had a very strong binding against granule cells, for example. And I will show you some of these cases a little bit more in detail. This was a 40-year-old male patient, again with severe catatonic syndrome over 1 year already. He was not speaking anything and had a catalepsy. And the EEG, MRI, and CSF only showed non-specific findings. Here is the MRI. You see here is more white matter lesions, but not more. The antibodies were negative, but the patient was so severely ill, did not merely respond to classical therapy. And then the PET imaging again showed in the left hemisphere hypermetabolic changes along different cortical areas. You see it here. And on this tissue-based assay, we found a strong antibody signal against cilia on hippocampal granule cells. You see it here. So we diagnosed an autoimmune catatonia and did a successful therapy with steroids, plasmapheresis, and rituximab in coordination with the colleagues from neurology. And in the meantime, we have analyzed the first 119 patients, analyzed with this method. So this was a retrospective analysis. And there might be surely an overestimation of positive findings because we have many patients for organic diagnostic workup. And we discussed this very openly in this publication. But it was very impressive that 18% of these patients in CSF had a positive screening test, only 9% in serum. So the CSF seems to be much more sensitive. And most of these patients had antibodies against vessels. You see it here, vessels of different sizes. 7 patients had antibodies against granule cells. I have presented one of these cases in the the hippocampus and cerebellum. And 2 patients had antibodies against myelin structures. You see this here. 2 patients also had antibodies against Purkinje cells. You see it here from the cerebellum. And 1 patient had an astrocytic pattern, which turned out to be GFAP antibodies. So the antigen in this patient was known. All the other patients were negative for the well-characterized neuronal antibodies. But what is this anti-vessel pattern? So antibodies against vessels, what does it mean? We found them in the CSF of all these patients, but most of these patients were patients with recurrent episodes. These were not the first episode patients or in chronic patients. These patients mostly had white matter changes in MRI. And in 5 of 9 patients, we started an immunotherapy because they had other inflammatory changes, and only 2 patients benefited at least partly. And in the further course, we have seen that these are antibodies against endothelial cells. So we now think that they might not be pathophysiology relevant for the disorder, but perhaps these antibodies might lead to a blood-brain barrier dysfunction, and then make or can be the cause for other pathophysiological processes. Even more interesting was this granule cell pattern. This was found in 8 patients, and most of these patients had EEG pathologies. And you know, the granule cells, they are glutamatergic cells, thus there might be a glutamatergic dysregulation in these patients. And in 6 patients, we started an immunotherapy because they also had other inflammatory changes. And all of these patients show at least partial improvement. So this seems to be a very important pattern. But to summarize, there might be an overestimation of positive findings because we have a very pre-selected cohort. It is important to know that all these patients were negative for the well-characterized neural antibodies. None of them had NMDA receptor antibodies or something like that. And in the antibody-positive patients, we find more often increased albumin quotients. So it's signs of a blood-brain barrier dysfunction and white matter alterations in MRI. And we have already treated 12 of these patients. And 9 patients showed at least a partial clinical improvement. Again, this was a retrospective workup of clinical cases. It is no controlled study and no randomized study, though there are many limitations. But I think we can conclude that novel anti-CNS antibodies in the CSF may be relevant for a subgroup of patients in psychiatry. And the next step would be to look for the exact antigenes of these antibodies and on the functional relevance. It might be the case that some of these are irrelevant, but some of them, especially the patients who had antibodies against granule cells, might have functional antibodies. And in line with this expansion or expanding spectrum of antibodies, we have also observed an expanding spectrum of clinical syndromes with an autoimmune cause. And I will give you some examples of patients with OCD, affective disorders, and of the association with neurodegenerative syndromes. And the link between OCD and autoimmunity is longly known. You all know the PANDA syndrome, which was described here with 50 cases already in 1998. So it is something which is known relatively long. Here is one case we had on our ward, no PANDAS case, but still a probable autoimmune case. This was a 59-year-old male patient who had an exacerbated OCD for 3 years. So it was no acute onset, already 3 years. And the diagnosis of OCD was already made 15 years ago. This is relatively late for OCD because normally you have symptoms already in the first or second decade, but nevertheless it was no acute onset. And in the MRI we found this lesion which was abnormal, then we did automated MRI analysis, and we found, interestingly, atrophy in the orbitofrontal cortex on both sides. And in the serum, we found several autoantibodies in this patient. He had ANA antibodies, thyroid antibodies, mitochondrial antibodies. You can see it here, Yo1 antibodies. So there seemed to be an autoimmune predisposition, but there was nothing specific. And the case was then very interesting when we found in serum as well as in CSF a strong binding against basal ganglia. This is something we have never seen in our psychotic patients, for example. Yes, you have not seen this cluster before. So this seems to be something specific for OCD. And then we did a steroid pulse therapy, like in multiple sclerosis. And again, this is only one case, so there might be a placebo effect, but nevertheless, the Walbach scores, they went down directly after the cortisone therapy, and they remained relatively stable under an ongoing psychotherapy then. And the patient reported that he had the possibility to distance from the obsessive symptoms then. And if we look on the pathophysiology of OCD, this case makes sense because we have antibodies against the basal ganglia. We have a subcortical problem. We have an atrophy, which might be secondary to the antibodies in the orbitofrontal cortex. So we have surely a disbalance in the frontal and subcortical loops, as we assume for patients with OCD. And in the meantime, we are looking broader also in this patient group, and we have detected many cases or small case series with an autoimmune cause. For example, also a patient recently with a sarcoidosis and an inflammatory brain signals and obsessive compulsive symptoms. We did together a paper where we gave suggestions how to deal with these patients. And on our ward, we have a special ward, a psychotherapy ward in our hospital. We have adapted our diagnostic approach for these patients now. So since 2020, we offer a broad laboratory analysis, including the antibodies. We do an EEG and a broad MRI scan. And if we then have some alterations, we do an additional diagnostic things like CSF or genetic co-assessment. And we have analyzed the first 61 cases in a first publication. And we were surprised by ourselves because in 8% of these patients, we had a possible organic cause, and even in 8% a probable organic cause. So all in all, 16% of these patients, which we have selected for psychotherapy after a preliminary talk, had signs of an secondary OCD. And interestingly, most of these patients had autoimmune forms, but there were also genetic cases. So it's not all autoimmunity. There are also other reasons. For example, we detected one patient with a Bareitzer-Winter syndrome, which is a rare genetic syndrome. And we found brain involvement with typical alterations, which might be associated with OCD, with changes in orbitofrontal cortex, and so on. And we also try to use the research methods in clinical practice. So we do a relative broad MRI protocol in our patients. And if you then, for example, have patients with strategic lesions, we can do DTI analysis and better understand the lesion. And for example, here's a patient with a microbleeding in the nucleus caudatus, and here a patient with a more post-inflammatory lesion in the right globus pallidus. And using DTE tractography, it is possible to do a precise localization of the lesion. And for example, if you look on case 2, there was, if we bring it to the anatomical knowledge, there was an involvement of the motor control network and the indirect pathway, so we can directly understand which networks are involved in these patients, and perhaps also adapt our therapies, because here this pathway is dopamine receptor dominated. We are also doing neurotransmitter measurements in CSF more and more. This was one case with a postpartum OCD, possibly autoimmune in origin, and we asked, is there an effect of the antibodies, and do we find changes in the neurotransmitters? And for example, in these patients, we found high dopamine levels in CSF. And so we are using this technique more and more to get a better insight into the brains of our patients. So what is with affective disorders? Here one case again to start with. This was a very interesting case, mid-50-year-old male patient. He has a severe depression over 5 years. He got lithium, CBAF therapy and all the therapies. He had an allergic tendency, very high IgE levels in serum. And because of his comorbidities, he reported about improvement of his depression under steroids several times. And we thought, okay, this might perhaps something of an abuse, because the MRI looked largely normal. There were only non-specific white matter lesions. EEG was normal. And you all know that if you have steroids, there is a little enthusiastic feeling initially, and the energy is a little bit better. And we were skeptical, but we added then a CSF analysis in this patient, and there were slightly increased cell counts of 5 cells. It's borderline. Some laboratories say 5 is normal, others say 5 is 1 cell too much. But in our psychiatric patients, this is something which should, in my opinion, lead to further investigations, because we see it rarely in our patients. And we did that, and the well-known antibodies again were negative. But on this tissue test, we saw a very strong binding against astrocytes, in the glia limitans. So you see here this antibody binding, also here against some vessels, but this was a very impressive antibody signals we saw here. This is something which again can be found in GFAP antibodies, but these were negative in this patient in different cell-based assays. So we assume that this is a new antigen target in this patient. And then we said, okay, now we have a reason for doing an immunotherapy. And the patient showed really a rapid improvement of his mood under steroids. And we did a relapse prophylaxis azathioprine. And for example, you see here the follow-up. I think it was after 3 months in neuropsychological testing, and there was also a strong improvement in divided attention from T1 to T2. Again, here we find more and more patients with an autoimmune affective disorders, but clearly we cannot do lumbar puncture in all patients with depression, and there might be clearly psychoreactive causes. So we have, in a comment article, we have summarized some red flag symptoms also for these patients to do a pragmatic approach in clinical practice. And I will close my talk with the association with neurodegenerative diseases. We had patients on our wards with clear defined neurodegenerative disorders. For example, we found patients with a frontal temporal dementia associated with antibodies against axon initial segments. You see it here. Or we had patients with clear-cut genetic disorders, even like Huntington's disease. And in the CSF of this patient here, we found antibodies against myelin. So the association between neurodegeneration and autoimmune is well known, but perhaps this might also be a trigger for the production of antibodies in some of these patients. And if we detect these patients, we surely cannot cure the morbus Huntington clearly, but perhaps we can receive a modulation of psychiatric symptoms in a subgroup of these patients with antibodies in the CSF. So to summarize, I wanted to show that we have an increasing spectrum of antibodies, again, CNS structures. And in line with this, we find a broader clinical spectrum of patients. And for these patients, we might develop new treatment options through hopefully more and more specific immunotherapies. But it is also important to mention that these are only case reports and case studies, and we are talking about a small subgroup of patients. It's not the idea that we can say all psychosis patients should get cortisone or something like that. So these are very selected cases after a broad and a multimodal diagnostic workup. But for this small subgroup of patients, we can do something like precision medicine, and I think that we, in these patients, at least can prevent therapy resistance. And with that, I would thank to the head of my department, Professor Katharina Domschke, who is supporting me very much with this research, to Professor Ludger Theberts-van-Els, who brought this topic to Freiburg and who is doing all these projects together in our working group with me, and did all the papers together, to Harald Prüß, who is our collaborator for laboratory work and for the tissue-based assays, and today especially to Tom Pollack, who offered me the possibility to be here today. And thank you very much for your interest.
Wow, thank you, Dominique, for a really wonderful talk there. Let me just click off this talk so maybe you can see us a little bit larger now. Yeah, I didn't mention in the introduction then that so much of what you've written are case reports and case series, and the timing is interesting that we had this talk about the 6 neuropsychiatry cases that have changed the course of neuropsychiatry. And you know, I don't think it would be an exaggeration to say that your group has had quite a big role in the resurrection of neuropsychiatric case studies. I mean, there are so many out there, and you know, you might not get this impression from today's talk, but the degree of psychiatric and phenomenological detail in your case studies is also a lot, as one might expect from a German. Anyway, but you know, there's a lot of psychiatry in there. It's not just the neurology and the neuroimmunology, and that is really wonderful. And you know, we hear a lot of things. There's a very skeptical tradition in the UK. We hear things being said about how data is not the plural of anecdote, or something like that. There's a real sort of devaluation of the role of case series, and of course there will be criticisms that the work that you show is not presented in a randomized control fashion, that perhaps you are using assays that do not have wide acceptance. But then on the other hand, the cumulative weight of what you have shown clinically makes it very hard to sort of refute the reality of what's happening. So the phrase that comes up to me is something that you hear a lot on social media: is huge if true. And you know, I think, and my question is, how can we move forward, do you think, to make some of these findings more universally applicable? Do you think we need the trials, or do you think, as perhaps there's a fairly good tradition, or long tradition at least in neurology, of just going ahead and doing the, you know, making treatment standard practice, and you can do the trials a few years later? What do you think?
Yeah, thank you very much for this very important point. I think there are many limitations if you are presenting case reports, absolutely clear, and the next steps have to come now, and we have to do larger studies using these antibody tests. And for example, these antibody tests were not evaluated in healthy controls, and so it's very important to do that. And for example, in Denmark, there is now a group, Michael Benrose, they have healthy control group with CSF material, which is not so easy. So this group has to be analyzed with the same method, for example, and then you have to do the comparisons. Yeah. And these are very, very important next steps. We have to compare different antibody testing methods, because every laboratory is doing its own test. It's not that, but there are different tests available, and so they have to be compared. These are very important methodological aspects which have to be solved. And on the other hand, we need surely clinical trials. I don't think that we can do placebo trials with patients with a clearly limbic encephalitis. If you have brain inflammation, you have pleocytosis, you have the MRI, you have signal intensities in the hippocampus and so on. So these patients, there it's relatively clear from knowledge that they have to be treated. But with the borderline cases, and these cases I presented are borderline cases, and we have to do clinical trials where we compare these patients with possible autoimmune psychosis or psychiatric syndromes against placebo, and this is what we have applied for, and what is surely a next important research step. And from the understanding side, we need to understand what the effects of the antibodies are. So we need the epitopes, the antigen targets in detail. Then mouse models are necessary. We have to look whether the clinical syndromes can be triggered by the antibody in mouse models and so on. So there is much work to do. It's only a first starting point regarding that.
But it's interesting because what you outlined there sounds like a research program of 10 or 15 years or something. And yet when I see the case studies that you're reporting, I feel I might be missing out on possible treatments for some of my patients. And I mean, again, I've mentioned we have a slightly skeptical tradition. I know even some people in this room today who wrote a paper entitled "Are we over-investigating our patients in psychiatry?" and wrote quite an eloquent defense of the idea that we might be. And I wonder, so much of what comes out from what you do is you have the resources, which I understand are perhaps backed up by the way in which health is funded in Germany, a sort of more insurance-based company where you can really go to town on investigating these patients. And of course, we have a very different system in the UK where every test has to be sort of justified. And again, one thinks about low and middle income countries where they're in an even more sort of restricted state. And I wonder, do we just have to wait for these trials, or do you think there's a way that we can move forward in this more restricted clinical settings beyond what we're currently doing?
I think, for example, your paper was very helpful in this regard, because in an optimal way, we would offer even a broader diagnostic as you suggested, but you did selected red flag symptoms for patients. So we selected the high risk patients, and then we do the investigation of these patients. I think this would be a first step, and it's a very important first step. And then we select these patients. And in an optimal world, I would think we should be able to do it broader, but perhaps then we will, at the end of the day, do it too broad. And then we should also, again, look back in the data and look, okay, which are the patients afterwards which needed all these investigations and which perhaps not. So I think there are many questions to be resolved, but such a suggestion as your paper with clinical red flags is an important first step in this thing.
Yeah. Thank you. I have this image that we're kind of working at the tip of the iceberg, and in Freiburg, you've all got your scuba gear suit and you're sort of round the base of the iceberg, seeing what interesting stuff is there. Let's have a look and see if there are any questions in the chat. So, seems to be quite a few. So the first question is from Jashan. Autoantibodies in the serum must cross the blood-brain barrier. In case of no prior disruption due to infections or tumors, how do these cross and cause the symptoms? And I think there's actually a second related question from Simon here. Are there data on altered CSF markers for blood-brain barrier dysfunction attributable to psychiatric medications?
Yeah, this is a very important thing, and something which we are thinking a lot, because we have this large number of patients also with a blood-brain barrier dysfunction, which is non-specific. In our cohorts.
And can you just tell people how you measure that blood-brain barrier dysfunction?
With the albumin quotients. So albumin is produced in the liver and not many in the CSF, and we make a quotient then. And if there is a high quotient, we know that there must be a barrier dysfunction, and there is too much albumin in the brain. And we have at least 20% or something like that in our cohorts. And we have not found an association with medication, but mostly all of these patients were on medication. There still might be the case, and there is some data who is supporting this also. And yeah, the triggers for autoimmunity we currently know are infections, are tumors for antibody production. And there is also the possibility that there are B cells into the CSF producing antibodies, but the exact pathophysiology behind antikörper production and the movement into the body are still to be evaluated and investigated. Yeah. don't know whether you can.
Well, no, I mean, if you look at the literature, there seem to be a lot of factors that are associated with blood-brain barrier disruption, and even some studies suggesting that sort of acute psychosocial stress, for example, could cause it. And I'm a little bit skeptical of those, but I think certainly there probably are many factors that are contributory. But again, whether just allowing a few antibodies into the blood-brain barrier, into the CSF compartment is enough to cause disease, or whether what you really have to allow in are the antibody-producing cells, I think is another major question that we need to answer. Let's scroll down. So Vashishta Polisetti has a question. She says, great talk, very exciting findings. In the 119 patients, how is the family history like in those positive patients? And in patients with a past psychiatric history, how was the past treatment response to psychotropics? And should we take Fazekas grade 1 seriously in young patients?
So I will start with a family history and with the past treatment response. These were things we have not detailed. We have no detailed analysis, and we have to mention these are single antibody types and different processes. So it is hard on such a very small sample size to give answers on that, and to look on white matter lesions is this is surely nothing specific. I don't want to give the impression that this should lead to a treatment or something like that. It was just to show that this were the findings in these patients, and but we surely need further inflammatory markers to treat our patients.
Yeah.
Fazekas is the score for white matter lesions, right?
I think that's right. Does anyone confirm that the Fazekas score? No, I mean, I think Graham Blackman actually has a meta-analysis out soon showing that patients with the first episode psychosis are more likely to have non-specific white matter lesions generally, and of course that isn't an indication that they are all all immune.
Surely not.
Let's just go on to people who've raised their hands. So in order, we have a raised hand from Gary Price. Gary, if you want to put the video camera on, that'd be great.
Can you hear me okay?
We can hear you, we can't see you, but that'll do.
Okay, you don't want to see me anyway. Sorry, I couldn't get, my chat wasn't working. Great talk, thank you. I never get to come to these because they're always on my clinic day. I was wondering, I've come across 1 or 2 cases of IGLON5 in the recent past, and that's quite unusual, as you know. And you mentioned neurodegeneration, and I was wondering how in the case of IGLON5, I've just been trying to work it out. How did the tauopathy, how you feel these antibodies lead to a tauopathy? I just wondered whether you could just touch on that and help me out.
Yeah, I've never seen a patient with IGLON5 antibodies, so to be honest, I'm not an expert in this field. We only checked in very in cases with sleeping disorders and so on, where we thought that there might be a cause which might be comparable with the classical syndrome, but I have never seen a patient regarding that, and I'm not completely familiar with the exact pathophysiology. I think it's still under investigation and not clearly understood. But to be honest, I don't know the latest literature. Don't know, Tom, do you know that?
No, I know there's a large IGLON5 study group that got going last year, and I think this is one of the main questions they're interested in. I think it is interesting because it breaks down traditional boundaries between autoimmunity and neurodegeneration. I'm not sure if the causality is clear in IGLON5, and I think also what it has done partly is it's caused a lot of people to revisit the issue of pathogenic autoantibodies in primary neurodegenerative disorders, including things like Parkinson's disease and Alzheimer's. And again, this is a topic that comes up sort of every 10 or 15 years, and I think there's a bit of a resurgence in it at the moment. But again, no clear answer for you, Gary, I don't think.
Oh, okay. Thank you very much.
And next we have David Okai. Hi, David.
Hi, I really enjoyed the talk. Thanks very much. Very educational. I mean, I think the thing I particularly liked was the balance of a consideration about the phenotype and the assays and the consideration of the assays. One of the things that is often misunderstood is that assays are not a dichotomous value as positive, negative, but actually there are oftentimes a consideration as to the level of the titer response as well. You mentioned this in your talk, but the idea of the fact that people are using different types of assays, and I wondered specifically in your thoughts as to whether you might have had a difference in findings if you'd used the live assay versus the fixed assay for the NMDA cases.
In our hospital, we do not use live cell-based assays. We don't have them in our laboratory, so we only use the fixed cell-based assays. And so the cases I have shown were detected using these tests. And the most patients I have presented here were detected by this screening tissue-based assay. And this test is a screening test, and it is sensitive. But as I said, it is very important that it doesn't tell us in many of these cases the detailed antigen epitope. So there are further tests to be developed. And after we have detected the exact antigens, and I think Tom is more the expert for the live cell-based assays because you are using them perhaps more often, but we don't use it in our laboratory.
No, David, I think that's a brilliant question, and I see there's a sort of spectrum of how permissive these assays are. You've got the Euroimmune on the one end, which really is fairly conservative. And I mean, we've seen patients who have, often is the wrong word, that we have seen patients with a sort of severe encephalitis who haven't tested positive on the Euroimmune assay, but have tested positive on the live cell-based assay, as is performed in Oxford, for example. But actually, I think the assay that Dominique is using is one step further in terms of its permissiveness, possibly, and I don't think direct head-to-head studies have been done. But my guess is that it would encounter even more positives than a sort of live cell-based assay, because this is just a tissue-based assay, and as Dominique says, it's antigen agnostic. I think the real question comes, if we're going to do studies, sort of trials, which assay do we use? Do we want to use a conservative one, or do we want to use a permissive one? And my feeling is, if we use a conservative one, we're probably not necessarily going to get much more information. And actually, it's a toss-up, right? Because if you use a more permissive one, you're going to get more cases that would certainly be missed. But at the same time, you may well be inviting cases that have antibodies of no relevance. So there's a real balancing act here, and I don't think anyone has great answers.
Yeah, it's almost tempting to use both at this exploratory stage, isn't it?
Yeah.
Precisely for that reason. Thanks very much.
Okay, so we are actually at 1 o'clock, and we only have an hour slot, I'm afraid. I know there were a couple more questions in the chat, and perhaps I can talk with Dominique, who can perhaps answer those questions outside of the talk. Thank you very much, everyone, for joining. I think we got around 75 attendees in the end, which is fantastic for a fairly unorthodox time for these meetings. Just leaves me to say thank you so much to Dominique Andres for coming here, for presenting all your exciting data, and I hope we can have a follow-up from you at some point soon. Thank you.
Thank you so much for your interest.